Okay, so I'm James Lyons-Weiler. I'm the president and CEO of IPAC, the Institute for Pure and Applied Knowledge, and I founded IPAC EDU. We had something like 2,500 to 3,000 people take courses as a result of COVID so they could learn immunology and statistics and keep up with the bad guys as they were lying with statistics and lying about public health policy. So, vitamin D, problems with vitamin D dosing actually first came to my attention when I saw a friend of mine, a colleague of mine, Keith Baggerly, give a presentation about it online. I knew Keith from many, many years ago when I worked with the Early Detection Research Network in cancer. And I was really pleased to see that he was advancing the knowledge of the problem with vitamin D mistakes. So that's what my talk is going to be about today. I'm just going to share some slides. I probably won't even take up the whole 5 minutes. I'm not going to go into great detail, but you can bet that you can find more detail about this at Popular Rationalism on Substack. I've written one article. I'm going to write another article about it. And of course, you can find a lot of articles there. We're transitioning everything at IPAC EDU over to IPAC EDU online. So it's a social media platform that we're creating to bring about 4,000 or 5,000 people together to do great work. But let's get underway here and talk about one of the mistakes, or many mistakes. We're going to hear from many of the speakers here about all the mistakes that have been made over the years, but in vitamin D dosing. So everybody who's speaking today will probably go over this and clarify it, but the RDA, the recommended daily allowance right now, is somewhere around 600, 800 international units a day. And we want to distinguish that from the tolerable upper limit intake level, or the upper level. And part of the mistake that was made, and I'm going to make it very, very painfully clear about how and why they made the mistake, it was a inferential error. It wasn't a mathematical error or a statistical error. It was just looking at statistics wrong and doing analysis wrong. And this is documented. It is not controversial. This mistake is absolutely, published in the peer-reviewed literature. The Institutes of Medicine, 100%, now the National Academy of Sciences, and have validated it. But what they did was they said that the lower 95% prediction interval for the upper limit, not the RDA, but the upper limit of exposure, was determined using something that allowed that level to be too low. And the way that it was too low is because that they handled individual study averages as if they cover the entire distribution of diversity among individuals. And it's really obvious when you think about it. If you know about statistics, it's called regression to the mean. The idea that 97.5% of individuals, might actually be above a certain level based on inferences, based on what the averages are telling us, is patently false. You can't get there from here, to quote my friends from New England. And so I came up with this cartoon. It's, if you want a copy of it, go to popularrationalism.substack.com. So let's say that my job as I'm an engineer and I'm going to make bridges in my town, and I know that there's diversity among the trucks. And so I want to be sure that the trucks aren't too high, and an acceptable risk so that we can have to reroute a certain amount of traffic is 2.5% of trucks will have to be rerouted. Right. And so because of the variation among the trucks, what I do is I go to the literature and I look at the average of different kinds of trucks, maybe different categories of shipping needs or companies or produce or something. And I take those averages and I go, well, listen, on average, the average of all these trucks are lower than this. And so I can actually have the bridge at a certain height, or maybe they're higher than this. And so, I can have my bridges a certain height. And so if I get that wrong and I don't look at all the diversity of trucks that are out there, then the math that you do when you look at the average of distributions rather than the average of all individuals in the population, is you're going to have a lot of trucks that are hitting the bridge, right? That you don't anticipate, and so you're going to have to reroute a lot more traffic. Um, and that's what's happening here. So I won't go through it in great detail, like I said, but there's more variation among individuals in the population than there is variation among averages among studies. That's the problem. So they really made a silly mistake, and it's not controversial. Another example of how to understand what they said about that upper limit is by taking the average. If I said to you that most classrooms averaged above a passing grade, it's certainly not the same thing that saying that 97.5% of students passed. Those are two different inferences. And so the Institutes of Medicine, they try to release some new DRI limits, recommended intake. Catherine Ross, Catherine Ross shared that, and they still are very, very, very low compared to what the data would actually support. Um, Here's one of the studies that got it started. Some Canadian scientists looked at the statistical error and said, hey, we published this. This is in the journal Nutrients in 2014. Now it's 2026, so it's been a while. And because of that statistical error that I told you about, then it was confirmed. If you look at independent data, and this is some people associated with grassroots health data, they analyzed it, Heaney et al. They said, hey, look, it's actually you have to have higher intake than we thought. And Carol is on there and so on. So, this is a problem that's very well known to this particular group. Our job today is to make sure that the Institutes of Medicine, I'm sorry, I misspoke, that HHS understands that there are consequences for them. They're continuing to distribute the wrong information. There's never been a revision of the RDA. There's never been a revision of the upper limit based on in fact, even though we know that the problem was there, the data are published, and they can now determine what a more reasonable limit would be. Um, and it's been the frustration of everybody that's going to be presenting today for years and years that no one seems to be able to move the needle. And Robert F. Kennedy Jr. is the secretary of HHS, and I spoke with him about this problem, and I wrote up something for him, which he ended up distributing across HHS. And hopefully there'll be some action, but we're not seeing that action yet. And so we got to keep the heat on. We want to bring it to the public and say, there's a problem here that the science as it stands is not being translated into policy. And really, it basically boils down to correcting the website here and there across HHS for the most part and other publications. But there are other consequences that we're going to recap at the end, like maybe we need to update medical education. And maybe we need to study the consequences of you enroll somebody in a clinical trial for research and they have low vitamin D. I mean, why would you do that? You want to increase the health of the population, then you should take a look at what's happening when, doctors are practicing ethical medicine, let's call it that. So there have been debates, there have been positions on it. There are health consequences for pregnancy and maternal. We're going to get into all of this, I'm sure. People on the call are much more expert than I am. Children and adolescent deficiencies, very important. Geriatric population, very important. But let's just say that there's a problem because while the knowledge base has shifted, the policy hasn't changed. And we know the health consequences, but we need to talk about it. So I'm happy to turn it back over to you, Jen, and stop sharing